Hepatobiliary Cancer, the final frontier. These are the voyages of the Starship Medical Oncology, its continuing mission to explore strange new targets, to seek out new therapies, to boldly go where no chemo has gone before.
I,
That
Michael, I don't know what you're doing, but I love it. And if anyone didn't think we were nerds before, they definitely know that we truly are.
Absolutely. That I will have you know was Chief Scientist Spock, as famously portrayed by Richard Nixon, providing his insight into the difficult journey of treatments of our topic today, the double header of biliary tract and hepatocellular carcinomas. So, unfortunately, Richard Nixon is not here in the booth with us. It's just me, Michael, and Josh, as always. And we're going to take you on a Trekkian type journey through these two very difficult to treat cancers.
Leonard Nimoy would definitely be proud of what just happened.
I'm sure they're both rolling in their graves right now.
Peacefully rolling.
Peacefully rolling in their graves. I was going to do a Sir Patrick Stewart, but then I thought he might actually take offence to it.
Well, he is alive, so yes, I think he
Yes,
would. I might just get the ball rolling and start.
Yes. So, Josh, take it away with cholangiocarcinoma before this episode spirals completely out of control.
Yeah, we don't actually talk about oncology at all. So,
no,
I'm going to talk a bit about the biliary tract cancers. So, it's a pretty heterogeneous group of cancers, which include your extrahepatic and intrahepatic cholangiocarcinomas, gallbladder cancers, and pulmonary cancers. So it's difficult to really go through all of these with justice. So I'm going to try and group them and talk mostly about cholangiocarcinomas today. Now, these cancers, all of them, really are diagnosed generally at a late stage. They have terrible prognoses, and usually surgical removal, surgical excision is just never an answer because it's encasing important vessels, it's spread beyond the local area, and that's just unfortunately the reality that we have at present. Now, over the past decade, multiple trials have happened. So this includes drugs which I've never heard of, and Michael, maybe you have, but cediranib. Have you ever heard of cediranib?
Nope, never heard of that.
Nope. Okay, cool. There's not just me. Erlotinib, cetuximab, panitumumab, ramucirumab, and merestinib are just multiple trials of these drugs, and none of them have shown improved overall survival, improved progression-free survival, and the standard of care hasn't changed since cisplatin and gemcitabine, and we still use this as a backbone today.
It really does seem like it's the sort of cancer that just they're throwing everything at it and seeing if it works, and it's really been difficult to have a therapy that has a benefit.
100%. And because a lot of these patients present so advanced, they are very unwell. So you can't just have a thing, I'll start chemo, see how they respond. They're at a point where they're in hospital, they have obstructed gallbladders or obstructed livers, and they need surgical intervention, and they need months sort of recovery from that. Now, median overall survival, Mikey, what do you think for biliary tract cancers or cholangio with treatment?
Well, you've painted a very, very grim picture, Josh. So I would have to say somewhere in the realm of short to medium months, 3 to 6 months, thereabouts.
Generally 11.7 months, so maybe I painted too bad a picture, but still pretty terrible.
Still
and the 24-month survival rate is like 15.7%. So we need new therapies. That's the summary. When we talk about cholangiocarcinoma specifically, the nomenclature has changed slightly depending where you live in the world, but usually they arise from epithelial cells of the intrahepatic or extrahepatic bile ducts. Highly lethal due to advanced presentation, as I've mentioned, and they've now more recently been classified as, it really includes sort of bile duct cancers from intrahepatic, perihilar, and distal biliary tree. Now, epidemiology, it's about 3% of GI malignancies, and in the US of A, there's about 41,000 primary liver and intrahepatic bile duct cancers diagnosed annually, and about another 12,000 then extrahepatic. Now, One of the other interesting things is that this has increased over the last 30 years, but that's also to be expected with better screening, better CT, tomography, those sorts of things, and we can actually pick these up. There's interesting risk factors, which I think we should discuss here today, Michael. What are your thoughts as some risk factors for this GI malignancy?
I'm going to pick at the low-hanging fruit here, Josh, and say smoking.
Everything is with smoking, so that's a very safe guess. Anything else that, going back to your physician days when you were sitting your final exams?
Oh, gosh, that was so long ago.
But not far enough.
But not far enough, no. I still have a vague recollection of it. I'm going to have to press pass on this one, Josh. Could you please illuminate us with your superior knowledge?
Yeah, no, that's fine. I had to refresh my own memory, but primary sclerosing cholangitis is one of those really big risk factors that you mentioned. Other things, so liver flukes, if you live in Thailand, so if you've got a Thai patient, that's something to really think about. And there's a strong association between intrahepatic stone disease and cholangio, which I never knew about. The other common ones, although not strongly associated, meaning there's not randomized controlled trials looking at it, that sort of prospective stuff, but elevated blood sugar levels, obesity, and metabolic syndrome. As expected with most cancers, obesity can influence direction of patients' health. Now, histology, the majority of the cholangiocarcinomas are adenocarcinoma, with squamous cell carcinomas being responsible for most of the remaining cases. What is interesting, though, and this is probably the more important bit, is the biology of these cancers. So a lot of them do have immunogenic features, including IC molecules, PD-L1, CTLA4, those sorts of things, which we have discussed previously in our podcast. And there's a strong tumor microenvironment. So early studies have demonstrated clinical activity in biliary tract cancers, including durvalumab, a PD-L1 inhibitor. And that's what I'm going to be talking about today. Surprise. Now, chemo has immunomodulatory effects in multiple cancers. So what that means is that it changes the tumor microenvironment and actually improves the efficacy of these PD-L1 inhibitors, these CTLA4 inhibitors, and make the cancers more susceptible to these extra drugs. So the question that these really smart people who develop these trials had was, if you add immunotherapy to the chemo, could it improve the outcome versus chemo alone in biliary tract cancers? Stay tuned to find out after these ads. No, there's no ads, but after the brief pause. So this trial is called Topaz 1, which is an amazing name, and it is a practice-changing trial.
I was going to say a fairly recent trial as well. I only first heard about it earlier this year.
Yeah, really recent. So they were collecting patients from 2019 to 2020. It was a randomized double-blind global phase 3 trial. It was looking at the safety and efficacy of durvalumab plus gemcitabine and cisplatin, which is that backbone I mentioned previously, versus the placebo, which is just the chemotherapy. This is first-line treatment in patients with advanced biliary tract cancers. They were randomized as a 1-to-1, which is great, and they screened 914 patients, and of interest, only 685 patients were randomly assigned to treatment. Michael, do you know why?
Gosh, you're really coming at me with the questions this time, Josh. I am guessing that a significant proportion of them may have either progressed or they might have had autoimmune causes of their cholangiocarcinoma.
I'm guessing they probably progressed and weren't well enough to have it, but I haven't read that in the trial, but that's just my suspicion. With the demographics, what we do note is that there's a significant Asian population in this particular trial, which is great because it's quite common there. ECOG performance status of 0, about half of the patients as well. And it was divided, probably half of the patients had intrahepatic cholangio, 20% had extrahepatic, and the remaining 25% had gallbladder cancer. They also stratified patients according to PD-L1 expression of less than 1% or greater than or equal to 1%. I'm going to cut to the chase and talk about the first cutoff. So first cutoff was done at 16.8 months of follow-up. And what they found, and this is a sad statistic, is that 58.1% of the patients in the durva group, so durvalumab, had died, and 65.7% in the placebo group had died. But the nice thing of this trial is that it was statistically significant. So patients who got the immunotherapy had a higher chance of responding and continuing to respond to this treatment than those that just had chemo, with a hazard ratio of 0.8% with a p-value of 0.021. So median overall survival was 12.8 months in the durva group and 11.5 months in the chemo group. You might be like, Josh, that's only a month and one and a bit months, but that's actually significant in this population cohort.
Yeah, it sort of speaks to how grim this disease is, though, that and how difficult, as you mentioned, it has been to treat, that this small but significant benefit is still hailed as a breakthrough.
Well, a huge breakthrough. And the best part is that this is only an interim follow-up of 16 months. I want to see the 2-year follow-up, the 3-year follow-up, because we should see that hazard ratio get wider. I suspect there will be patients who, I'm going to assume, continue to respond.
Continue to respond, yeah.
Exactly. And so the Kaplan-Meier curves, it will be in the link in the bio of this trial, actually shows that the two arms do start to deviate, probably at that 6-month mark. You can see before the 6-month mark, the chemo, interesting enough, the chemo arm is slightly better. And I wonder whether just it was a cohort of patients we need more study, more follow-up to sort of see. But you can see there is definite divergence of those curves. Moving on. Estimated overall survival rates at the 12-month, the 18-month, and the 24-month. So at the 24-month, the estimated overall survival was about 25% in the intervention arm and 10% in the control arm. So that's good. That's good. Showing that there's a significant response. Now, complete response, you actually see some complete response in the intervention arm. So about 7 patients versus 2 patients in the control arm had a complete response with their disease, or 2.1% versus 0.6%. Small numbers, but still realistic numbers. And if you look at people that had partial response, it was 24.6 versus 18.1%. And disease control was seen in 85% of the intervention and 82% of the control arm. I've already sort of blown my whistle and given the really good result of overall survival at 24 months or predicted. But what was interesting is that the PD-L1 expression of less than 1%. So it's a hard one. When you're looking at the forest plots, it looks like everything crosses that midline. But I think we need some more time to really identify whether PD-L1 expression does influence outcomes. And if I had a patient today and this was an option, I would definitely apply to give them durvalumab based on the current stats and really the limited toxicities in what is a really dire cancer.
So, Josh, are we able to get durvalumab in Australia for this indication at the moment?
I'm so glad you asked. But before I give you the answer to that, I didn't talk about PFS, but PFS was also statistically significant with a hazard ratio of 0.75 and a p-value of 0.01, which is a difference of about 2.5 months, or a bit under 2 months, actually. So going to your question, yes, you can. In Australia, there is currently an access program through the parent company that does produce this drug, and they're looking there. I don't know if they're looking, but there are definitely options available, because durvalumab off the PBS in Australia, this is the one this is how we fund our drugs, is about $13,000. So if you respond, that's a lot of money ongoing.
Mm. And I guess we don't know yet, but was there a sort of a time limit for the durvalumab? Because we know in other cancers we cap the administration of immunotherapy to 2 years. I guess we haven't gotten there yet, but was there anything in the protocol that you saw, or is it sort of just durvalumab, give it as long as we can?
That is a really, really good question. I don't know. I'd have to go through the trial again to actually see, but I'm going to take a hedge and say either 1 or 2 years they'd be offered the durva.
It might also be a case where there are so few patients who make it, or a few patients that make it to that stage and they just don't know. So it might just be here we have a bunch of patients at 2 years, we'll just keep on giving them the drug.
Yeah, I think so. And I know this is a bit of a brief trial today. Normally we kind of yak on again and again, but I really
a couple of yakkers.
We're yakkers. I wanted to just highlight that this drug is available, and if you have anyone who's good enough performance-wise and well enough to go on this treatment, please do try and sort of reach out to the drug company to see whether or not they would help fund it, or maybe the patient can self-fund it, because it looks like the early stats, although not a hard bar to reach, have definitely shown PFS and OS survival. And if you're looking at drug toxicities, which is something that everyone wants to know about, it's going to be very similar to that of any other immunotherapy trial you get. So any grade adverse events of the intervention arm was 92% or 92.9 versus 90.1%. And serious was about 15% in the intervention and 17% in the control. So more people in the control actually had worse side effects than those in the intervention arm. So really shows that the drug does not cause that many ongoing toxicities.
And Josh, one more question,
I love a
because
question.
because we're engaged in a furious tennis match here of questions.
We are. I like giving them, not receiving them.
Did the trial? I'm guessing the trial excluded patients with past history of autoimmune disease because, as you mentioned in your your physician's exam level question with regards to causes of biliary tract cancer, a lot of these patients will have primary sclerosing cholangitis, primary biliary cirrhosis, and those often go hand in hand with other autoimmune conditions like autoimmune hepatitis. I'm saying this because I had a patient earlier this year who did have that horrible cornucopia of autoimmune diseases. And when I sat him down to talk to him about treatment, this was actually when I first heard about Topaz. There was absolutely no way I was going to give him Durva because he had all of these issues. So, but were those patients excluded from the trial?
Unfortunately, they were. So if they had documented autoimmune or inflammatory disorders or known allergy or hypersensitivity to any study treatment, they were excluded. And if they'd had prior immunotherapy, but likely these guys probably hadn't had prior immunotherapy, just based on the fact it was first line, or he was supposed to be first line.
Yeah, definitely. But I think that's a area of subtlety that might mean that a proportion of the patients who you see, particularly younger patients who present to you with cholangiocarcinoma, you may not be able to safely give them durvalumab, or in close consultation with a hepatologist, and if you're desperate, very closely monitor them. But we don't really have evidence that points to a benefit for those particular patients if we're going by the letter of the study.
100%. I feel like I talk a lot more normally about my trials, and today, for some reason, I've just smashed through it, and I don't know why. But the important thing is immunotherapy is going to become the backbone to a lot of these cancers. There's a huge amount of research looking at the microenvironment. Michael, do you know much? I've been reading a little bit about the microenvironment and its influences on targeted therapy, chemotherapy, and even immunotherapy. Have you done much investigation into the space?
I must confess I haven't very much, Josh.
Yeah,
So
well,
please tell me all of your knowledge that you have gained over the past 20 minutes.
no, look, I'm going to say 23 minutes, and it's wisdom, not just knowledge. No,
Oh, I'm terribly sorry. I'm underselling you there by 3 whole minutes.
3 minutes. So what I was reading earlier today was there's a lot of interest in, or in the targeted therapy field, there's some interest looking at targeted therapies, how they attach to cells, the microenvironment around the cell, and if you can stop the cells from essentially absorbing the targeted therapy, it can improve the efficacy of that drug. So they're looking at adding other drugs to really stabilize that microenvironment and make it more homogenous. By making things homogenous and equal expression of, let's say, whatever the targeted therapy is, potentially it can improve the efficacy and outcomes of these trials while decreasing the toxicity as well. So it's a really cool and interesting field that I think will very much reintroduce new drugs and old drugs and their usages in the oncology sphere.
I think that's sort of where we're headed with a lot of these drugs. I think that we have the technology, to use another outdated sci-fi reference, but a lot of the current research is looking at applying older drugs in new ways or new environments, as you say. And so it might be the case that it's the next body of research is variations on a theme rather than trailblazing new types of targets and drugs.
Exactly. That's exactly it, Michael. And or should I call you Richard? Mr. Nixon, would you like to maybe move on to your
Mr. President to you, young man.
Very, very good, Mr. President. Would you like to maybe talk about your cancer and a little brief introduction?
You've got to stop enabling me, because I will take any opportunity to break out into a vaguely appropriated voice. So jumping from one sort of grim cancer to another, I guess, Josh has very vividly outlined that biliary cancer is a very poor cancer to have in terms of prognosis, treatment options. The other cancer in this sort of area is hepatocellular carcinoma, and much like cholangiocarcinoma, there have been a number of studies that have looked at different agents, different chemotherapies, and really the standard of care has been a fairly old multi-kinase inhibitor by the name of sorafenib, and that's been the standard of care for a very, very long time. And it's a case where very few things that have been compared to sorafenib have been able to beat it. One of the contenders was lenvatinib, which we won't talk about in any great depth in this episode. We might in a later episode. But hepatocellular cancer is another one of these, what we call orphan cancers, where there's not really much out there, and potentially as a sort of feedback loop, there's less research going into it because there haven't been targets. So drug companies who invest millions and millions of dollars into developing these drugs, they're not actually guaranteed a benefit, and therefore not really guaranteed a slice of pie.
That's exactly it. And to add to how old this trial was, sorafenib was introduced in 2008. That was the NEJM article that showed it had improved PFS and OS, and it was only 3 months.
Yeah, and 2008 is ancient Rome by oncology standards. Like it is a very long time when you look at all of the things that have come and gone, or come in the intervening, 14 years.
Yeah, exactly. And the leaps and bounds made by other cancer types, it's not 3 months, it's years.
Yeah, absolutely. You look at the difference, as we have in a previous episode, stealth plug, in melanoma, the difference between 2008 and 2022, it's like night and day. Anyway, a little bit of background on hepatocellular carcinoma. As the name implies, it's a primary liver cancer that develops usually in the setting of chronic liver disease. It is more common than I was expecting, actually. Approximately 850,000 cases worldwide in 2018 alone. And interestingly, in terms of demographic spread, about 72% of these are estimated to occur in Asia, the highest rates in Mongolia and China.
Oh, explain why. Explain why.
I don't know that there is an explanation to explain.
Shame.
I know. I'm sure very smart epidemiologists have had a look at it, but I don't have a good explanation for that.
I thought you were about to launch into it, and then I was going to be like, "This is cool." I don't know.
No, but there is this sort of trend in the hepatobiliary setting, and you mentioned it briefly with your cholangiocarcinoma, that there does seem to be a significantly higher rate of these diseases in Asian countries. So hepatocellular carcinoma follows that trend. As one would expect for a cancer affecting such a vital organ as the liver, the worldwide mortality from hepatocellular carcinoma in 2018 was 780,000, making it the third most common cause of cancer-related mortality. Ouch. So it's beating out, it's beating out probably melanoma, pancreatic cancer, colorectal cancer. I would say that the two ones that beat it, I don't have their stats with me, but I would say the ones that beat it were lung cancer and potentially breast cancer, which are obviously much more common worldwide.
But it's not something you want to be the top third. You don't want to be third in this race. That's a very
no. You very much want to be avoiding the podium in this sort of race. So hepatocellular carcinoma affects men 3 times more commonly than women. Again, there's explanations, but nothing has really conclusively been proven as to the cause of this. And it's especially prevalent in patients with cirrhosis or chronic hepatitis B. It's estimated that 1/3 of patients with liver cirrhosis will develop HCC in their lifetime, and this is why, in Australia at least, there's protocols for ultrasound based monitoring of HCC for patients with cirrhosis.
You mentioned hepatitis B, which I think is really interesting. I thought in a lot of Asian countries, at least going back 15 years, the public health push to vaccinate people with hepatitis B wasn't there. Is that maybe an association that's the reason why we have such high levels in Asia?
It could be, but that doesn't explain, for example, why the rates are not as high in places such as Africa or South America, where I would imagine the push is similarly, I don't want to use the word lacking, but potentially unavailable. The resources aren't there.
Mm-hmm.
So it is a potential explanation, I guess, but it doesn't explain why it's so concentrated in Mongolia and China.
Very true.
Hepatocellular carcinoma accounts for approximately 75% of primary liver tumours, and the remainder, the majority of the remainder, are cholangiocarcinomas, what Josh mentioned, intrahepatic cholangiocarcinomas. Early stage cancer is treatable by resection, liver transplantation, or ablation, and it's at this point that I should probably mention the Barcelona liver cancer staging, which is a very, very complex and very different staging system to the usual TNM staging that we use for cancers. And that's because it takes into account the degree of liver cirrhosis using the Child-Pugh score, the degree of portal invasion, portal hypertension, as well as various other factors that I won't go into, but we will include a link to a algorithm in the episode description. Suffice it to say that when you have Barcelona stage A and B, you can use stage A, you can use things like liver transplants as a curative rate or a curative therapy. Stage B, where the hepatocellular carcinoma is a little bit more widespread, you can use things like TACE or ablation. And it's really when you get to stage C or stage D that you start to look at systemic therapy. So coming back to hepatocellular carcinoma, they have a very poor prognosis when they get to this Barcelona stage C or stage D. The previous standard of care, as mentioned, was sorafenib way back in 2018. But sorafenib does have significant side effects. Common side effects include diarrhea, cytopenias, mucositis, hand-foot syndrome, and hypertension. So it's not without its toxicities. Which brings us neatly to the study IMbrave 150. It's one of these atezolizumab trials where they insist on having IM and then some word. We have IMbrave, IMpower, IMvigor. It's not quite Topaz in terms of its catchiness, but it's at least distinct.
I really like it. I think it's better than the Keynote. Like everything, there's like 800 Keynote trials, and at least in Brave, there's not like 800 equivalents. So you're like, I don't know what number it is. Keynote 189, Keynote 776. Like, I'm not going to remember.
Yeah, well, you make a good point. I don't know where they got the number 150 from, because they're all of these trials are 150 or 133.
Maybe they hide the ones that are bad.
But it's not like there are 150 IMbrave trials, as you said.
True.
Anyway, so IMbrave was a comparison of atezolizumab, which is a PD-L1 inhibitor, and bevacizumab, which is a VEGF inhibitor, and it was comparing those with a standard of care sorafenib. It enrolled patients with unresectable or metastatic disease. They were ECOG 0 to 1, so functionally very fit, and they had a Child-Pugh score of A. And both of these things are potential areas of limitation to this study that I'll come to in a bit. Exclusion criteria, as mentioned with the Topaz trial, autoimmune disease was a exclusion criteria. So anyone with autoimmune hepatitis and cirrhosis and HCC from that was excluded. Admittedly, probably a small proportion of our patients with HCC, but no less significant for that. Patients who had co-infection or untreated hepatitis B or C, which is very important, so you can't have hepatitis B or hepatitis C and get on this trial.
Can I ask the question? Would that, I don't think that still holds true for hepatitis C, given it's so curable, and even hepatitis B with entecavir to control it. would you exclude your patient from potentially giving this? I know we haven't talked about the result, but
Hmm.
if theoretically atezo is better than standard of care, which I think our listeners can probably guess where we're heading.
Which our listeners will have to listen to the whole episode. We can't spoil it right at the start. Got to string them along a little bit.
Yeah, would you treat the patient? Because I probably would.
I think practically you would, and I think that you would have to, at very least, co-treat them. I think practically speaking, you would have them on something, especially if it's hepatitis C and you can cure it fairly quote unquote easily. So, but nevertheless, it was an exclusion criteria, and I'm not really sure why. Perhaps it was because the patients with sorafenib, they're at risk of cytopenias and you might not want to risk reactivation. And so in the sorafenib era, you might have needed to treat antecedent viruses beforehand. But I think you make a very good point. We know that atezolizumab and bevacizumab is not immunosuppressive in the same way as something like sorafenib is. So you can probably get away with enrolling these patients or starting them on trial on treatment sooner, at very least, while you're co-administering a anti-hepatitis therapy. The other thing it could be down to is drug interactions. We can't ignore the possibility of entecavir or all of the other virs that escape my memory at this point. I once knew them all. Interacting with atezolizumab or bevacizumab, or simply the study coordinators not knowing, because this is an experimental treatment. Other exclusion criteria, getting back on track, thank you, Josh, was included untreated or incompletely treated gastric or gastroesophageal varices, which were deemed to be actively bleeding or at a high risk of bleeding. So again, a very important consideration to have. And when we come to the side effects, it'll become abundantly clear why this was an important consideration. So for hepatocellular carcinoma, when I looked at those inclusion and exclusion criteria, I thought there's no way you're getting a decent number of patients with hepatocellular carcinoma that have Child-Pugh A cirrhosis as opposed to B or C and are a decent ECOG status. But hey, they managed to scrape together 501 patients at 111 sites in 17 countries. So they've done a good job. They've done a very good job with recruitment. Josh is not convinced, ladies and gentlemen.
I'm dubious. Look, I don't run this trial, but most of my patients have some form of cirrhosis, especially if they've been affected for a very long time. So I wonder if maybe they were just very early stage, because there's lots of ways to assess if someone has cirrhosis. So if they do it a certain way, it might not actually be picked up.
Well, they could have had Child-Pugh A cirrhosis.
Yeah.
Well, they had to in order to get onto the trial. But let's face it, the majority of cases that I've seen, and probably the same with you, Josh, of patients who come to us nowadays looking for atezolizumab and bevacizumab, because, spoiler alert, it is a standard of care.
What?
They do tend to have more severe disease. It tends to be Child-Pugh B or Child-Pugh C by the time they get to this stage. And again, as a result, their ECOG status tends to suffer.
But you'd still treat them, realistically. You don't have another option.
No, you don't. You don't really have another option, exactly. But anyway, so there are a couple of things I really like about this trial. Number one, patients, so there were a decent number of patients. It was randomized in a 2-to-1 ratio, which I think, as we've said on this podcast before, generally means that the investigators were pretty confident that atezolizumab and bevacizumab was going to be better than sorafenib, and they just wanted to make it more appealing to patients to get on the trial. Maybe that's how they got the 501 patients in the first place. You're twice as likely to get this newfangled immune therapy than the old tablets. The other thing I like about this trial is treatment was continued until unacceptable toxicity or loss of clinical benefit. So patients could actually continue on atezo-bev beyond progression, beyond radiological progression, if the clinician observed evidence of clinical benefit, which is very much what tends to happen in clinical practice. If a patient is tolerating treatment well, if they're doing well, if they're functionally good, sometimes we do try and continue treatment beyond clinical benefit. It's a bit more restricted in Australia, where you have to swear up and down that the patient hasn't progressed on this treatment to continue getting funded by the PBS. But in practical settings and with less restrictive therapeutics, we sometimes do continue treatment beyond progression of disease if the patient is getting a clinical benefit. So I thought that made it a little more relevant to standard sort of clinical practice as opposed to the weird and wonderful world that is the land of trials. Patients who either temporarily or permanently discontinued one agent could also continue on the other if it was thought there was a benefit. So, say you have a really bad immune-mediated side effect, you could continue on the Bev for what good that does you, while even though you stop the atezo. So it's not an all or nothing thing. So there's a little bit of flexibility in the trial structure, which I thought was good and made it a little bit more real to life. Endpoints. The co-primary endpoints were overall survival and progression-free survival, standard stuff. And secondary endpoints were the overall response rate, the duration of response, and again, secondary endpoints that I really like: the time to deterioration of quality of life, physical function, and role function, so occupation, which was assessed using the European Organisation for Research and Treatment of Cancer, the EORTC, their quality of life questionnaire -C30, which is a very commonly used quality of life questionnaire in clinical trials. So there is a real holistic approach to the sorts of things that can go wrong with hepatocellular carcinoma. It's not just the disease-related stuff, it's the quality of life, it's the loss of function, and this really does reflect what we see a lot of in hepatocellular carcinoma in patients afflicted by it. I won't get too much into the demographics because I've already taken up whatever time Josh has saved on his very succinct summary of Topaz.
The important points, Michael. It's the important points.
It's the important points. But I will just mention the majority of patients in terms of their antecedent cause of HCC. Majority of patients, it was deemed to be hepatitis B. 49% in the atezo-bev group and 46% in the control group.
I had one other question. When, with the demographics, and you said I think it was a multi-site trial, did they mention the countries which they recruited from primarily?
They did in the supplementary appendix, which I didn't have a look at, but I can say that 40% of patients were from Asian countries that excluded Japan. So they were from mainland Asia. 60% were from the rest of the world.
That's really interesting. Thank you.
Yeah, it is. So, in terms of the results, let's just crack right along. The median overall survival, and this is from an update from last year, was 19.2 months in the atezo-bev group versus 13.4 months in the sorafenib group. So, hazard ratio of 0.66. More than half of patients in the atezo-bev group made it to 18 months. Progression-free survival, these numbers are always going to be smaller, but it was 6.8 months in the atezo-bev group versus 4.3 months in the sorafenib group. But again, more than half of patients in the atezo-bev group made it to 6 months in terms of progression-free survival. Over a quarter of patients in the atezo-bev group had a response. 5.5% of patients had a complete response, which for hepatocellular carcinoma is just astounding, much like cholangio. Interestingly, by comparison, 0.0% of patients in the sorafenib group had a complete response.
The only thing worse than that is when the drug actually does harm.
When it actually accelerates the cancer, exactly.
Which don't worry, the drugs that we give do not accelerate cancer.
No, that's kind of the opposite of what we go for in oncology. In terms of the quality of life data, the time to deterioration in quality of life in the atezo-bev group was 11.2 months versus 3.6 months in the sorafenib group. So patients are not only surviving longer, but they're maintaining their quality of life for a lot longer.
That's really interesting. So overall survival, you were saying, sorry, you did give the stats like 10 seconds ago. It was, 17.13 months, right? 17, approximately. It's about 4 months.
I mean, it was 19, Josh, but don't worry. I'm only my feelings are only mildly hurt that you're not listening.
That's okay. I am. It's just the percentages. But it's interesting that the quality of life is maintained. And my question at this point is how? If they're progressing or if their overall survival is that, progression-free survival isn't a lot, why is their overall quality of life maintained? Does it go into that?
It doesn't really. It just sort of presents the data, and I did have a bit of a fish around as to why. My gut feeling, though, is that a number of these patients were continued on treatment beyond progression as it was allowed, if there was deemed a clinical benefit. So these patients who were getting a quality of life benefit would have continued, and whether the atezo-bev slowed an otherwise potentially rapid progression and therefore enabled patients to maintain functionality for longer, I honestly don't know. But the differences in the groups, and basically what it amounts to is patients were given a questionnaire and asked basically how they're feeling in a number of areas. And so the differences in the data, in the quality of life data, is quite marked. So, for
Astounding.
example, yeah, it really is. So physical function, which is another thing that they assessed, 13.1 months versus 4.9 months in the sorafenib group. So patients in atezo-bev group are maintaining what they would deem an adequate physical function almost over 3 times, almost 3 times longer. I can do maths. What are you talking about?
Your maths is as good as mine.
Yeah, we definitely got into this job for the maths. Almost 3 times longer than in the sorafenib group.
Do you
And
think it's
patients,
also sorry? So do you think it's also the diarrhea component? Because I vaguely remember when I treated people with sorafenib, diarrhea was always this problem.
well, not just necessarily the diarrhea. The other problem that I've had with sorafenib is the hypertension,
Yeah, definitely.
which is not as big a feature as bevacizumab. We know that we're very alert with bevacizumab causing hypertension, but the times that I have seen it, it is debilitating. People have headaches. They have exacerbations of pre-existing cardiac disease. They have renal impairment and all of the problems related to that. So it can be a big problem. And I think the diarrhea obviously is a much more visceral problem. It's a huge impact in patients' quality of life when they have to go to the toilet every 5 minutes.
Yep.
So that is almost certainly another thing that's adding into this. But it's the data is there, and it's very suggestive of not just a outcome benefit, but a quality of life benefit, which I think is very good data to have, especially when you're trying to sell the patient on this
I
treatment.
don't know if you really have to sell them. It's a great option.
Yeah, it really is. It really is. And some patients, and Josh, you've probably had this as well. Some patients say, well, I'm going to take this treatment. I might live longer, but is it actually going to make me feel better? And in this case, you can sort of point to this and say, well, the evidence is that it will make you feel better for longer.
That's exactly it. With these subset of cancers, there is a conversation that has to be had about I can make you live longer, but if you're stuck in bed, it's terrible. And I feel bad, Michael. I've made you digress so much when you're talking about your results, and I think we've just gone to adverse effects because I was like, I'm interested about this. But did you want to go back and sort of finish off your summary of outcomes?
No. I was done. That was pretty
Oh,
much
you were
done. I
done.
was actually, I was just going to talk about some subgroup analysis where the benefit was slightly less clear, because I suspect this is an illustrative case of how subgroup analysis frequently don't tell the whole story, because the subgroups where the benefit was less clear, and I've selected the subgroups where there were a decent number of patients. So we can't use the age-old excuse, oh, there were 3 patients
There were
in
4
this
this
subgroup.
time.
Not this time. Not this time. But the subgroups that the benefit was less clear on didn't seem to make too much sense to me. So benefit was less clear in patients who were ECOG 0, who had a high alpha fetoprotein of greater than 400 nanograms per milliliter. So very elevated, potentially corresponding to burden of disease. No extrahepatic spread, and non-viral disease etiology. Now, I can't really thread the needle as to why atezo-bev appeared to be less beneficial in these sorts of patients, because it's sort of patients who are fitter, but also might have worse disease, but also might have better disease. It doesn't really make much sense. And so, the lesson I've taken from this is that subgroup analysis are frequently fraught with difficulties when you try to come to interpret them, and shouldn't really color your assessment of the overall benefit unless the difference is striking or explainable.
100%. I think maybe this is my hypothesis of the situation. If you've got hepatitis B induced hepatocellular carcinoma, you have the mechanism. You know why they've got the cancer. If their cancer is due to a different etiology, you did mention it. Maybe it is more aggressive. Maybe the pattern of spread in non-hepatitis B related HCC is more localized to the actual liver itself rather than extracapsular spread. And given that you get different outcomes depending on the pathophysiology of the cancer's aggressiveness and things that we probably don't yet truly understand.
It's possible. I guess the other thing as well, potentially, in terms of sort of focusing on the non-viral disease subgroup, is that viral hepatitis-induced cirrhosis is theoretically treatable. You can treat the virus, as we've said. We're awful at this point, as far as I'm aware. Now, I'm no gastroenterologist, so there might have been some new updates, but
Not
NASH
yet.
cirrhosis, yet. NASH cirrhosis, autoimmune hepatitis, those sorts of things, there's still a very, very challenging set of conditions to treat. And so the survival impairment might not necessarily be from the cancer. It might be from the fact that their liver is finally giving up the ghost because we're not managing the underlying cause.
Yeah, that's a great hypothesis. We should work on doing our PhDs on that.
Well, if you can do a PhD on anything, you can definitely do one on that. In terms of safety, because Josh, I know you're eager to hear about this. I'm just going to focus on the grade 3 to 4 events. They're broadly similar across the group. The main grade 3 to 4 event was hypertension, as we've mentioned, and this is where the varices questions come back into the fore, which we put aside briefly before. We know that hypertension, and particularly portal hypertension, obviously, is a major risk factor for the development and subsequent bleeding of varices. So it is very important when you're starting these patients on bevacizumab, or to a lesser extent sorafenib, but bevacizumab especially, that there is a structure involved that they can get their regular surveillance scopes for variceal monitoring, because the last thing you want is for someone to develop an burst of varices related to portal hypertension that has been made worse by the administration of your bevacizumab. So that's
That
just
would be a
something to keep in the
disaster.
back of your mind. Yeah, absolute disaster, and it can be very difficult to get under control.
I think it's a case of this, that with my patients, sometimes we delay commencing treatment, even if it's a couple of weeks in this situation, to make sure that they can have the Bev and the Atezo, because you don't want to get them in hospital, end up delaying everything by months, and then the outcome is definitely going to be poorer in that situation. But a couple of weeks difference between commencing treatment is not going to change overall survival or PFS.
Yeah, I definitely agree, and I think if you hit upon one of the tenets of oncology, Josh, which is try and get all of your ducks in a row to start with, knowing that prolonged hospitalizations, prolonged delays are going to have significant impairments in outcomes. And so if you get things like, in this case, surveillance scopes, hepatitis screening, treatment of viruses, all that sort of stuff, if you get that all done, even if it takes you a couple of weeks, it's going to save you, and more importantly, the patient, a lot of grief, a lot of morbidity, a lot of mortality down the road. You're not impairing their outcomes because, as we have said before, immunotherapy tends to take a couple of months before it starts to work. So you're not going to be significantly impairing outcomes, but you will save the patient a lot of grief if you address these sorts of reversible things first.
As they say, proper planning prevents piss poor performance. I've always wanted to say that on a podcast, so here we are.
There we go. Josh's life mission has been fulfilled, and now he's
I'm done. I
just
can
going to
retire.
he's gonna ride off into the sunset.
Pretty much.
The adverse events, otherwise, they're pretty standard. So the most common adverse events of special interest related to the atezolizumab were hepatitis, rash, and thyroid axis issues, hyper or hypothyroidism. In terms of bevacizumab, hypertension, bleeding, and hemorrhage, 6% of which was grade 3 to 4 in severity, and proteinuria, which we know is a area of monitoring for bevacizumab, renal hypertension-induced nephropathy. They were all present, but none of this data is new.
So, Mikey, if you had to summarize this trial in 2 sentences with some numerical values so Josh can remember, give it to me in 2 sentences. What's your assessment?
This is Josh's way of saying that he's sick of listening to my voice.
Nah, you got a lovely voice. I might edit that out, but I might not.
If I was going to summarize this sentence in 2 sentences, I would say Atezo Bev almost doubles overall survival. It triples almost quality of life preservation, and it really does appear to be a best first line therapy for hepatocellular carcinoma, with a few caveats in the clinical space.
That's a great summary. And I will briefly summarize my trial of Topaz as well, just so if people went ahead to the 54-minute mark, they can now summarize this whole discussion in 30 seconds.
They've already skipped ahead, yeah.
To me. No, the median overall survival that were found with durvalumab, gemcitabine, and cisplatin versus the control arm of just chemotherapy in Topaz 1 shows that median overall survival of 12.8 months versus 11.5 months in the control arm with a hazard ratio of 0.8. So an improvement, but more information is needed moving forward to see if we can make that more significant as the Kaplan-Meier curves diverge. And with progression-free survival, again, we see an improvement in the intervention arm with durvalumab, which is 7.2 months versus 5.7 months. This is a difference between going to your kid's wedding or not. So these months, although they look small, are really imperative. And I think that's really concluding the Topaz 1.
Very nice packaging there, Josh.
Thank you. On an optimistic note.
On an optimistic note, yeah, absolutely. So I think that we should wrap it up before Josh starts complaining about listening to my voice anymore. Thank you very much for listening. Join us next week where we'll be talking about metastatic bladder cancer and taking yet another deep dive into the wonderful world of immunotherapy. And I cannot guarantee that Darth Vader might not make an appearance. We'll have to wait and see.
I can't wait.
Fantastic. Thanks, Josh. And thank you, everybody, for listening. We'll see you next week.
See you then. Bye.
Bye.